which is the most important intravenous heparin that can act both in vivo as well as in vitro. Now there are different types of the heparin like unfractionated heparin, low molecular weight subcutaneous heparin as well as fondaparinux. So these are the different types of the heparin already we have seen, and then we have started with the warfarin. Warfarin is the oral anticoagulant drug. So already we have seen that warfarin, how it acts. Warfarin acts by, in simple terms, antagonism of the vitamin K. So vitamin K dependent clotting factors like 2, 7, 9, 10, these 4 factors are mainly blocked when we are using warfarin. Now from what this term warfarin comes, this warfarin is basically coumarin derivatives. It has been seen that a spoiled clover leaf or spoiled clover hay, it has been seen that they are cattle poison. And then on the behest of the farmers, some scientists have researched in the Wisconsin, and then this warfarin comes as a product of anticoagulant. That's why this warfarin mainly stands for the Wisconsin Alumni Research Foundation Coumarin. Warfarin, W for Wisconsin, Alumni Research Foundation Coumarin, in warfarin. Apart from the warfarin, there are different other coumarin anticoagulants. Already you have seen, these all are the oral anticoagulants, and these oral anticoagulants mainly acts in vivo. There is no action of these oral anticoagulants in vitro, that is outside of our body. And this warfarin is the most important oral anticoagulant, and it has been extensively used, but the main problem is its therapeutic index is very narrow. So it has been seen that when we are using warfarin, there is always chances of the more bleeding. That's why we have to monitor the actions of the warfarin, particularly so because this warfarin is highly protein bound, approximately 99% protein bound. Its bioavailability is also high, approximately 100%. That's why if there are some other drugs that can displace the warfarin from its protein binding site or inhibits its protein displacement from the protein binding site, so there may be increased availability or decreased availability of the warfarin. And warfarin is also metabolized by the cytochrome P450 enzymes. That's why if there are some drugs that inhibits the P450 enzymes or induces the P450 enzymes, ultimately there will be changes in the warfarin concentration in our blood. So ultimately there may be subtherapeutic effect or there may be increased bleeding. So warfarin have to be monitored regularly, and this monitoring is mainly done by means of the prothrombin time and its congener international normalized ratio, INR. You have read in the pathology about the prothrombin time, how it is to be measured, activated partial thromboplastin time, and the INR, that is the international normalized ratio, which basically gives a uniform data. So how we can interpret whether the warfarin is in the therapeutic range or not. This warfarin ultimately takes some time to act. Approximately its duration of action is 3 to 7 days. So in case of the, for example, pulmonary embolism or deep vein thrombosis, when we start treating a patient, we have to start with some heparin, because heparin acts instantaneously. Already you have seen. Instantaneously action is the heparin. Low molecular weight heparin, already we have seen, they are beneficial in comparison to the unfractionated heparin. So we should start with the low molecular weight heparin, and we should start with the warfarin in the same time. Low molecular weight heparin, we can stop it after 3 to 7 days, and we have to continue the warfarin for a long period of time, because warfarin takes action, it takes time for its action. Because there are clotting factors 2, 7, 9, 10, these clotting factors again have to be diminished at least less than 40% for its action as anticoagulant. So already those coagulation factors, those are already present in our blood, that have to be diminished, and it usually takes time. That's why warfarin action usually takes time. Factor 7 is the shortest T-half, only 6 hours. That's why when we are giving the warfarin, factor 7 level usually falls first. And after factor 7, factor 9, factor 10 and last factor 2, that is the prothrombin level falls. So we can assay the factor 7 to see whether the prothrombin, whether the warfarin action is occurring or not, like this. So let's just continue with this. So already we have seen about this vascular phase, coagulation phase. We will discuss about this fibrinolytic phase today itself, because we will read about the fibrinolytic and antifibrinolytic drugs. This vitamin K already we have seen, anticoagulants, heparin, everything about the heparin we have discussed, how heparin acts, what is the mechanism of action of the heparin, what is the advantage of the low molecular weight heparin over the unfractionated heparin. Already we have discussed. Heparin-induced thrombocytopenia and how it is to be treated. There are some direct thrombin inhibitors. This bivalirudin, ergotamine, lepirudin. And we have started with the warfarin. This is the mechanism of action of the warfarin. This is the way by which the warfarin, the different coagulation factors, diminish of the coagulation factors when we are using warfarin. Already we have discussed. Warfarin is mainly it is mainly a enantiomers of dextrorotatory and levorotatory isomers, and we can see the S form is more potent and metabolized by ring oxidation, and this ring oxidation is done by the cytochrome 2C9. And it has also been seen that some are poor metabolizer, some are rapid metabolizer. And it has been seen that in the Western world, in some cases, we have to check the cytochrome P452C9 level also, because before using the warfarin, because many of the patients are poor metabolizer and cannot metabolize the warfarin adequately. Warfarin is rapidly and completely absorbed from the intestine, 99% plasma protein bound, already I have discussed, and it crosses placenta and is secreted in milk. That's why warfarin is teratogenic. So when you are asked that what anticoagulant can be given in pregnancy, the answer is heparin. Already we have seen the heparin cannot cross the blood-brain barrier, but warfarin crosses the blood-brain barrier and it has teratogenic effects. That's why warfarin is not to be given in pregnant patients. It is also secreted in the breast milk. So the international normalized ratio is the way by which we can measure the actions of the warfarin. So when we are using the warfarin, firstly, in every week we have to test the prothrombin time, and from its derivative international normalized ratio, and if the if this INR is very high, there is more chances of the bleeding, and if it is very low, there will be subtherapeutic effect. Okay, so this is the international normalized ratio. It is to be calculated at patient's prothrombin time in seconds by mean normal prothrombin time in seconds to the power of international sensitivity index. It is fixed. So from this we can derive about the INR. So the adverse effects of the warfarin, the most important adverse effects of is the bleeding. Time and again I am saying bleeding. If this international normalized ratio is greater than 4, there is more chances of the bleeding. Usually in many of the indications, the INR have to be kept between 2 to 3 or 2.5 to 3.5. But it should not cross the 4, because there will be more chances of the bleeding. Most important are the ecchymosis, epistaxis, hematuria, bleeding in the gastrointestinal tract. Intracranial or internal hemorrhages may also occur, and that are quite fatal. Bleeding is more likely when the INR is greater than 4, already I have discussed. Apart from this, there may be some reversible alopecia, that is, if we stop the warfarin, the alopecia, that is the hair loss, will be stopped. There may be dermatitis and there may be diarrhea. And another very important adverse effect is the skin necrosis. The skin necrosis is the rare but serious complication of the warfarin. Prevalence you can see 0.01 to 1%, occurs 2 to 5 days after initiation of the warfarin, usually occurs after high dose of the warfarin. Why it happens? Because warfarin blocks the, already we have seen, vitamin K dependent clotting factors 2, 7, 9, 10. Apart from this, warfarin also inhibits protein C and protein S. This protein C and protein S is already present in our plasma. These are the natural coagulant. Warfarin also blocks this and acts as an anticoagulant. Due to the diminished level of the protein C, there may be chances of the skin necrosis This is known as the warfarin-induced skin necrosis. It is rare, but if it happens, it is quite devastating. You can see this is the warfarin-induced skin necrosis, lower abdomen and breast. Ultimately, that may be fatal also. So, treatment of the bleeding due to oral anticoagulants. If a patient, we are giving the warfarin and the patient is complaining of the bleeding, there may be bleeding from, there may be ecchymosis, there may be hematuria, etc. So, first we have to stop the anticoagulant, we have to stop the warfarin. We can give the fresh blood transfusion. This supplies the clotting factors and replenishes the lost blood. Alternately, we can give the fresh frozen plasma because the fresh frozen plasma contains large amounts of the clotting factors. Vitamin K1 is the specific antidote. Vitamin K1, already we have read, this is the phytonadione. Phytonadione is the vitamin K1, which is the specific antidote of the warfarin. But usually it takes 6 to 24 hours for the clotting factors to be resynthesized. Because synthesis, it usually takes place, it takes time, and released in blood after vitamin K administration. So when there will be bleeding due to the warfarin toxicity, it is quite common if we are not monitoring enough the INR. If there is some drug-drug interactions, because warfarin on the one hand it is metabolized by the cytochrome enzymes, on the other hand it is highly protein bound. That's why different drugs or different foods can ultimately displace it from its protein binding site or inhibits, or it can induces or inhibits its metabolism by the cytochrome enzymes. So there may be increased chances of the bleeding. When the bleeding happens, we have to first replenish with the blood or the fresh frozen plasma, and at the same time we have to give the vitamin K1 or phytonadione injection. So you can see dose regulation. In case of the prophylaxis of the deep vein thrombosis or like thrombosis in other veins, the INR should be kept between 2 to 2.5. Treatment of the deep vein thrombosis or pulmonary embolism or transient ischemic attacks that can happen in the brain cerebral circulation, hip surgery, the INR is to be kept between 2 to 3. Recurrent thromboembolism, there is history of the thromboembolism previously. Arterial disease like myocardial infarction or prosthetic heart valves, somewhat larger, somewhat higher INR is to be kept 3 to 3.5. So we have to measure the prothrombin time and INR, and accordingly we have to giving the doses of the warfarin. So there are some factors that enhances the effects of the warfarin. For example, if there is debility, if there is malnutrition, if there is malabsorption or prolonged antibiotic therapy, if there is liver disease, chronic alcoholism, synthesis of the clotting factors, in all these cases the vitamin K will be deficient. Already we have seen if there is some hepatic disease, if there is prolonged antibiotic therapy, so ultimately that leads to enhanced action of the warfarin. Hyperthyroidism and also newborns, because already we have seen in the newborns, in the premature infants, there are already deficiencies in the vitamin K. There are some factors that decrease the effects of these oral anticoagulants like pregnancy. In pregnancy, plasma levels of the clotting factors is higher. Nephrotic syndrome, here the drugs is bound to plasma protein is lost in urine. In nephrotic syndrome, there is proteinuria, large proteinuria happens, and already you have seen warfarin is largely bound to plasma protein. That's why it will be lost in the urine. Genetic warfarin resistance, what I am telling. So ultimately, since warfarin is mainly metabolized by the cytochrome enzymes, and in the pharmacodynamic also, so both pharmacokinetic and pharmacodynamic variability may be there. This is genetic variability. The affinity of the warfarin, vitamin K epoxides binds to the vitamin K reductase enzyme, which generates the vitamin K hydroquinone, is low. If there is resistance, if there is some genetic warfarin resistance, so dose of the oral anticoagulant is to be given 4 to 5 times higher. So it may happen in some of the patients, there may be some genetic warfarin resistance is there, where we have to give some high doses of the warfarin for its action. So contraindications of the warfarin is similar to that of the heparin. Already we have seen what are the contraindications of the heparin. Mostly if there is different chances of the bleeding tendencies. Apart from this, fetal warfarin syndrome may happen if we are using it in pregnancy. That's why it is to be contraindicated in case of the pregnancy. In pregnancy, we have to give anticoagulant heparin. So warfarin given in early pregnancy increases the birth defects, especially the skeletal abnormalities. Hyperplasia of the nose, eye sockets, hand bones, and the growth retardation can happen. Given later in pregnancy, it can cause CNS defects, fetal hemorrhage, fetal death, and accentuates the neonatal hypoproteinemia. So these problems can happen if we are using the warfarin in pregnancy. That's why it is not to be given. Drug interactions, several drug interactions can happen, large number of the drug interactions. For example, if we are using some broad spectrum antimicrobial agents, newer cephalosporins like ceftriaxone, cefoperazone, etc., that can enhance the anticoagulant actions. That is, there is more chances of the bleeding may happen. If we are using aspirin along with it, aspirin is an antiplatelet drug in low doses. So inhibits the platelet aggregation and it can cause GI hemorrhage, particularly if the patient have already some peptic ulcer disease, some bleeding peptic ulcer disease. So there may be chances of the bleeding. High doses of the salicylates have synergistic hyperproteinemia action. Salicylates means if the patient is in pain and we are using some painkillers, these painkillers have also some hyperproteinemia actions and that can synergize with the warfarin and increases the chances of the bleeding. Long-acting sulfonamides, it is an antimicrobial agent. Indomethacin, phenytoin, probenecid, that can increase. Chloramphenicol, erythromycin, celecoxib, amiodarone, tolbutamide, phenytoin, there are different drugs. So when we are using the different drugs, we have to check whether the interaction is there or not, and accordingly we have to decrease the dose of the warfarin. And on the other hand, the reduced warfarin action may happen when we are using barbiturates, when we are using carbamazepine, rifampicin or griseofulmin, because they induces the metabolism of the oral anticoagulants, because they induce the cytochrome P450-2C9 most commonly enzymes. Oral contraceptives, again, that can also increase the blood levels of the clotting factors. So when some patient is taking the oral anticoagulants increases the level of the blood coagulation factors. So actions of the warfarin will be diminished. So when the actions of the warfarin will be diminished, there may be problems in the, again, blockade of the veins or arteries may happen. That's why in these cases we have to increase the doses of the warfarin or other oral anticoagulants. Now these are the newer oral anticoagulants or novel oral anticoagulants. So until now we have read about the parenteral anticoagulant, parenteral, the indirect thrombin inhibitor heparin, the different types of the heparin, fondaparinux, low molecular heparin, etc. Then we have seen about the direct thrombin inhibitor, injectable like bivalirudin, lepirudin, argatroban, etc. Mainly these are used in case of the heparin-induced thrombocytopenia. Then we have seen about the oral anticoagulants. Coagulants mostly are different types of the coumarin derivatives or phenydione derivatives. The most common coumarin derivatives is the warfarin. But this warfarin, there are different types of the problems. What are the problems? Already we have seen. Warfarin, when we are using, there is always chances of the bleeding if we are not monitoring it adequately. Because if the INR is greater than 4, there is more chances of the bleeding. And if it is less than 2, there will be subtherapeutic effect. This warfarin has very narrow therapeutic index because it is largely metabolized by the ring oxidation by cytochrome P450-2C9, and it is also largely protein bound, 99% protein bound. So there will be more drug-drug interaction and drug-food interactions. So different drugs can enhance the actions of the warfarin or inhibits the actions of the warfarin. So these are the newer drugs, novel oral anticoagulants. These drugs usually do not require monitoring. These novel oral anticoagulants are mainly blocking either the factor 10 or the prothrombin. This can be given in a fixed dose. Usually long-term monitoring is not needed. The chances of the bleeding is also very less. The chances of the skin necrosis is less. So there will be beneficial effects, and in different trials it has been seen that its efficacy is also non-inferior to the warfarin or other phenydione derivatives. So direct thrombin inhibitor is the dabigatran, and factor 10A inhibitors like rivaroxaban, apixaban and edoxaban. These 4 are available in our country also. These 4 are known as the novel oral anticoagulants or NOACs. Okay. So what are the indication of this novel oral anticoagulants? The similar to lower the risk of stroke and embolism in patients with non-valvular arterial fibrillation. Warfarin is also given in the same indication, but again there is problems already we have discussed. So when there is arterial fibrillation, there is more chances of the cerebral stroke, because the embolism, the chances of the embolism is more, that embolus can lodge in the cerebral blood vessels and stroke can happen. So in case of the arterial fibrillation, if there is higher chances of the stroke, we can use more commonly these novel oral anticoagulants as prophylactic agents. Again, in case of the treatment of the deep vein thrombosis, prophylaxis and treatment, deep vein thrombosis may lead to pulmonary embolism. Treatment of both deep vein thrombosis and pulmonary embolism, and to reduce the risk of recurrent deep vein thrombosis and pulmonary embolism after initial therapy. Apart from this, it has also been given in some cases to decrease the chances of the myocardial infarction if there is any history of the myocardial infarction or acute coronary syndrome. So dabigatran etixylate, dabigatran is basically a direct thrombin or 2A inhibitor. It is basically a product which after oral administration is rapidly hydrolyzed to dabigatran, which is a direct thrombin inhibitor and which reversibly blocks the catalytic site of the thrombin. Again, the thrombin inhibitor. Okay, so there are catalytic site, they are blocking this catalytic site of the thrombin. That produces a rapid, within 2 hours, anticoagulant action. Though oral bioavailability is low, the anticoagulant effect is consistent, no laboratory monitoring is needed. Half-life is 12 to 14 hours and duration of action is 24 hours. Okay, dabigatran. Rivaroxaban, now more commonly used, rivaroxaban. It is a orally active direct inhibitor of the factor 10. Factor 10A, 10 to 10A, it is to be blocked. Its anticoagulant effect develops rapidly within 3 to 4 hours of the ingestion and lasts for approximately 24 hours. Half-life is 7 to 11 hours. Again, it does not require any laboratory monitoring. We can use a fixed dose every day, once daily dose. Rivaroxaban has found to be equally efficacious in the prophylaxis as well as the treatment of the deep vein thrombosis and pulmonary embolism, as well as preventing stroke in case of the arterial fibrillation. Side effects may be there is a bleeding, nausea, hypotension, tachycardia, edema can happen, but the side effect profile is less in comparison to the warfarin. So these are the antidotes that are already in the clinical trial that we can use, like andexanet, edarucizumab. So andexanet, aripagine, edarucizumab, these are antidotes for novel oral anticoagulants, because we know the antidote of the warfarin is the vitamin K, that is usually this is available widely. But the problem of the novel oral anticoagulants is antidote is not available, but there are some antidotes that is already in the clinical trials and already in the market, but again it is costly. So only drawback of the novel oral anticoagulant is if there is any toxicity, we do not have efficient antidote to it. But apart from this, just remember the name andexanet, aripagine and edarucizumab. These are the antidotes of the novel oral anticoagulants. So where we are using the anticoagulants? In summary, so we can use in case of the deep vein thrombosis and pulmonary embolism. We can use in the myocardial infarction. We can use in the unstable angina, rheumatic heart disease, prevention of the stroke in case of the arterial fibrillation, cerebrovascular disease, different types of the vascular surgery, prosthetic heart valves, retinal vessel thrombosis, extracorporeal circulation, hemodialysis, defibrillation syndrome or disseminated intravascular coagulation. So these are the different indications of all of the anticoagulants. Now already we have seen some anticoagulants are more used in some indications, some are more used in some other indications. So this is the indication of all anticoagulants, be it heparin or be it warfarin, be it novel oral anticoagulants. Okay. So after the anticoagulants, next coming to the fibrinolytics or thrombolytics, fibrinolytics. So already we have seen, so after the platelet plug formation happens, we have to destroy this platelet plug. So already there is plasminogen present in our blood, and from the endothelium, tissue plasminogen activator is released. This tissue plasminogen activator converts the plasminogen to plasmin, and this plasmin ultimately binds with this fibrin. Insoluble fibrin converts to soluble fibrin, and ultimately this fibrin becomes fibrinogen degradation products. That is, the meshwork of the fibrin will be degraded. So when we are using the different drugs like this fibrinolytic drugs, they are basically accelerating this process of the fibrinolysis. And these fibrinolytic drugs are mainly used in case of the myocardial infarction. So when there will be blockade in the coronary blood vessels by means of the thrombus, immediately we have to thrombolize, and this thrombolysis have to be done by means of this fibrinolytic or thrombolytic agents, usually if the patient comes early within the 4 to 6 hours. Okay. Now when a patient comes with the ST segment elevated myocardial infarction, the treatment of the choice is the percutaneous angioplasty. Okay, percutaneous intervention, that is the coronary angioplasty. But you know, for the coronary angioplasty, there needs a setup, there needs a trained hand, because it is not available everywhere. But if the patient comes early, so we can thrombolize the patients immediately, and there will be more chances of the survival in these patients. And after thrombolysis, if the patient survives, then we can do the percutaneous coronary intervention also. So otherwise, the thrombolysis or fibrinolytics are the life-saving drugs in case of the myocardial infarction, that is the heart attack. So immediately there is thrombus that blocks the coronary vessels. There is the ST segment elevation in the ECG, in the for example in your emergency, you can immediately thrombolize the patient after just checking if there is any contraindication of the fibrinolytic agent is present or not. Okay. So you can see plasminogen is converts to plasmin, and this plasmin converts to fibrin degradation products. So there are some activators and there are some inhibitors. These are the activators of this conversion of plasminogen to plasmin. So these are the drugs, these are known as the fibrinolytics. Streptokinase is the age-old drug, the previous drugs. The newer ones are the urokinase, Antiplatelet, Retiplase, Tenecteplase, etc. Apart from this, these are the some factor 13A, kallikrein, tissue plasminogen activator. These are already present in our plasma. There are some already inhibitors are present like antiplasmin, some macroglobulin are present already in our blood. And after this, we will read about the antifibrinolytic agents. Example of the epsilon aminocaproic acid and tranexamic acid. Those actions are just opposite to that of the fibrinolytics. Okay. So here fibrinolytic and antifibrinolytic agents acts. This is the fibrinolytic system. Okay. So fibrinolytics are the drugs used to lyse thrombi or clot to recanalize the occluded blood vessels. Recanalization. Recanal. The canal is occluded by the thrombus, mainly in case of the coronary blood vessels. So they are the therapeutic rather than prophylactic and work by activating by the natural fibrinolytic system. So they are basically accelerating the normal conversion of the plasminogen to plasmin. The enzyme responsible for digesting fibrin is a serine protease plasmin, which is generated from the plasminogen by tissue plasminogen activator. This tissue plasminogen activator is released from the endothelium, which is produced primarily by the vascular endothelium. So this venous thrombi lysed more easily by these fibrinolytics than the arterial, and the recent thrombi respond better. That is, if the thrombi is old, that is if the patient comes after, for example, 6 hours, the thrombi cannot be easily lysed by the fibrinolytic drugs. That's why fibrinolytic drugs is to be applied early in the course of the myocardial infarction. The clinically important fibrinolytics are streptokinase, Antiplatelet, Retiplase, urokinase and Tenecteplase. Okay. So streptokinase is the first one, which is obtained from the beta hemolytic streptococci group C. It is basically first is inactive, but when we are injecting it, it combines with the circulating plasminogen to form an activator complex, streptokinase plasminogen activator complex, that causes limited proteolysis of the other plasminogen molecules to generate the active plasmin. More and more active plasmin is generated when there is combination with this. They are non-fibrin specific, that is, that can activate both circulating as well as the fibrin bound plasminogen. Therefore, it depletes the circulating fibrinogen and there is more chances of the bleeding. That's why the streptokinase is lesser used nowadays. The more fibrin specific fibrinolytic drugs, the newer ones are more commonly used nowadays. And another problems of the streptokinase is the presence of the anti-streptococcal antibodies. The patient may suffer from some streptococcal infections beforehand. So in the patients, there may be presence of the anti-streptococcal antibodies. Now when we are using these streptokinase drugs and when the patient have already have anti-streptococcal antibodies, so ultimately that can inactivate the doses of this streptokinase. So usually a loading dose, large amount of the dose is to be given. Again, when we are using a large amount of the dose, since this is non-fibrin specific, so there will be more consumption of the fibrinogen already present in the plasma, there will be more chances of the bleeding and also there is more chances of the anaphylaxis and allergy also. So it is antigenic, can cause hypersensitivity reaction, anaphylaxis, fever, hypotension, arrhythmia can happen. So it cannot be used second time due to neutralization by antibodies generated in response to the earlier dose. So the patient may comes with myocardial infarction and on the history you have seen the patient have suffered from the myocardial infarction before and also. For example, 10 years previously there is another attack and the patient have was transfused the streptokinase. So you cannot give the streptokinase because the patient have already developed anti-streptococcal antibodies in them and in these patients if we are injecting the streptokinase will not act or otherwise you have to give very high doses of the streptokinase. So these are the drawbacks of the streptokinase. Urokinase is an enzyme isolated from the human urine but it is commercially prepared from the cultured human kidney cells. It activates plasminogen directly and has a plasma half-life of the 10 to 15 minutes. It is non-antigenic. Fever during treatment comes but the allergic reactions are quite less. It is indicated in patients in whom streptokinase has been given for an earlier episode but is seldom used now because the newer ones are there. Previously, if we cannot use the streptokinase, we can give the urokinase, but now we are mainly using the Antiplatelet, Retiplase and Tenecteplase. Antiplatelet is mainly developed by the recombinant DNA technology. It is a recombinant tissue plasminogen activator. So tissue plasminogen activator is basically synthesized from the vascular endothelium and this tissue plasminogen activator converts the plasminogen already present as a zymogen in our plasma to the active plasmin. So we are just recombinantly creating this tissue plasminogen activator and this is known as the Antiplatelet. So this Antiplatelet, it is moderately specific for the fibrin bound plasminogen, that is it is fibrin specific. Circulating fibrinogen is lowered only approximately 50%. Plasma half-life is 4 to 8 minutes, that is it can act instantaneously. Because of the short T-half, it needs to be given by slow IV infusion and often requires heparin co-administration. So we have to give the Antiplatelet as well as the heparin. It is non-antigenic, nausea, mild hypotension etc. may happen but it is expensive. Retiplase is somewhat modified form of the Antiplatelet which is a longer acting, otherwise it is more or less similar to the Antiplatelet. Tenecteplase is the latest one. It is genetically engineered substituted mutant of the native tissue plasminogen activator. Again some side chains are just cleaved. Higher fibrin selectivity, slower plasma clearance, longer duration of action and resistance to inhibition by plasminogen activator inhibitor 1. This plasminogen activator inhibitor 1 and 2 already present in our plasma and they usually slowly inactivates this, but they are also resistant to this. It is only fibrinolytic agent that can be injected intravenously as a single bolus dose. The previous ones have to be infused. So infusion is to be given, that usually takes time, but Tenecteplase can be given as just a bolus injection, bolus intravenous injection, that is a life saving. So within just 10 seconds it can be given, while Antiplatelet usually you can see requires 90 minutes infusion. Fibrinolytic therapy can be instituted immediately on diagnosis of the ST segment elevated myocardial infarction. Risks of the non-cerebral bleeding may be lower with tenecteplase, but cranial bleeding incidence is similar. With all these fibrinolytic drugs, there is chances of the bleeding, and the problem of the bleeding is more in case of like that of the intracranial bleeding. So when we are using the fibrinolytics, there is danger of the intracranial bleeding is there. What is the advantage of the tenecteplase over the previous ones? Tenecteplase can be given a single IV bolus dose within 10 seconds, just a IV injection. So a patient comes, for example, a patient comes with chest pain. In the emergency, you have done the ECG. In the ECG, you have seen there is ST segment elevation is there. It is known as the ST segment elevated myocardial infarction, a STEMI. When a STEMI is diagnosed, immediately you have to give some drugs. Immediately some oral drugs. These oral drugs are mainly the antiplatelet drugs and the statins. The statins, in the dyslipidemia class you will read about the statins. So statins, antiplatelet drugs like aspirin, clopidogrel, loading dose is to be given. And after that, if the patient comes early, within 4 hours, we have to institute with the fibrinolytic drugs. If there is no provision of the cath lab. If there is cath lab is there, we can jolly well start with the angioplasty, that is the percutaneous coronary intervention, PTCA. So, but in most of the cases there is no cath lab, so we have in the emergency we have to thrombolize or fibrinolyze the patient by means of the fibrinolytic agents. Now what fibrinolytic agents we will use? Previously we will use only the streptokinase. Streptokinase is cheaper, but there are problems with the streptokinase, because if there is previous streptococcal infection, if there is previous use of the streptokinase, there will be anti-streptococcal antibodies. So we cannot use. There is more chances of the bleeding. There is more chances of the anaphylaxis. So in all these cases, we cannot use. The newer ones are the Altiplase, Retiplase, Tenecteplase, etc. Of these Altiplase, Retiplase, etc. is to be given by infusion, and it usually takes time, approximately 1 to 1.5 hours. But Tenecteplase, we can give just a single IV dose bolus and it is life-saving. So it is clear about the fibrinolytic drug. So fibrinolytic drugs mainly used in acute myocardial infarction. Time and again, remember, this is a life-saving drug and acute myocardial infarction. Apart from this, it can also be used in deep vein thrombosis, pulmonary embolism, peripheral arterial occlusion, and also in case of the stroke. So it has also been seen when in case of the ischemic stroke, that is when there is blockade in the cerebral vasculature and the patient comes within the 4.5 hours, that is within the 4.5 hours, we can use the Altiplase. So Altiplase has been indicated in case of the cerebral ischemic stroke. Apart from this, both the Altiplase, Tenecteplase, Retiplase, all these are indicated in case of the ST segment elevated myocardial infarction. So these are the contraindications to fibrinolytic therapy. There are some absolute contraindications, like if there is some prior intracranial hemorrhage. Already you have seen, if there is some known structural cerebral vascular lesions, because if there is some cerebral vascular lesions like aneurysm, berry aneurysm, there is more chances of the bleeding. If there are some known malignant intracranial neoplasm, again there is more chances of the bleeding. Ischemic stroke within 3 months, if there is any history of the ischemic stroke and if we are giving this, there is more chances of the intracranial bleeding. Suspected aortic dissection, active bleeding or bleeding diathesis excluding the menses, significant closed head trauma or facial trauma within 3 months. So these are the absolute contraindications. So in these cases, we should not use the fibrinolytic drug, we should use only the coronary angioplasty. There are some relative contraindications, that is we have to weigh the pros and cons and accordingly we have to institute the fibrinolytic therapy. Like if there is some uncontrolled hypertension, systolic blood pressure greater than 180 and diastolic greater than 110, traumatic or prolonged CPR, cardiopulmonary resuscitation is given, or major surgery is done within the last 3 weeks, recent within 2 to 4 weeks internal bleeding, non-compressive vascular punctures. For streptokinase, again already we have discussed, if there is some prior exposure to streptokinase, prior allergic reactions to streptokinase, if there is pregnancy, active peptic ulcer, if there is current use of warfarin and INR is greater than 1.7, there is more chances of the bleeding. So these are the relative contraindications. So when we are instituting the fibrinolytic therapy, we should keep in mind about the absolute contraindication and relative contraindications of the fibrinolytic therapy. And accordingly we have to institute the therapy. If it is contraindicated, we have to just go for the PTCA or percutaneous coronary intervention or coronary angioplasty. Similar thing. Okay. Antifibrinolytic drug. So previously we have read about the fibrinolytic drug. Antifibrinolytic drug is just the opposite. It inhibits the plasminogen activation and dissolution of the clot and are used to check fibrinolysis associated bleeding. There are two drugs most commonly used, epsilon aminocaproic acid and tranexamic acid. Epsilon aminocaproic acid is a lysine analog that competes for lysine binding sites on the plasminogen and plasmin and blocks the interaction of the plasmin with fibrin. Just opposite of the action of the fibrinolytics. This is a potent inhibitor of the fibrinolysis, can reverse states that are associated with excessive fibrinolysis. So where it is to be used? Mainly it is used to counteract the effects of the fibrinolytic drug. Again, when there is toxicity with the fibrinolytic drug, we are giving the fibrinolytic drug and there is more bleeding, so we have to use the antifibrinolytic drug, bleeding due to their use. Apart from this, we can use in case of the hemophiliacs as an adjunctive value for controlling bleeding due to tooth extraction, prostatectomy, trauma, etc. So in these cases, if there is more chances of the bleeding, we can use the antifibrinolytic drug. Epsilon aminocaproic acid and in hematuria, if we are using this, that can cause ureteric obstruction by unlysed clots. That's why it is not to be used. It can also cause intravascular thrombosis. And in rapid IV injection, if it is to be given, it can result in hypotension, bradycardia, etc. That's why it is to be used cautiously when renal function is impaired. That's why the tranexamic acid is very commonly used. It is more potent than the epsilon aminocaproic acid. That's why it is more commonly used. It is 7 times more potent, preferred for prevention and control of the excessive bleeding due to cardiopulmonary bypass surgery. When we are using cardiopulmonary bypass surgery and there is excessive bleeding, we can use this. Tonsillectomy, prostatic surgery, tooth extraction, mainly in case of the hemophiliacs. In the previous class already we have discussed about the hemophilia, about the Christmas disease, deficiency of the clotting factors. So in these cases we can use this. Menorrhagia, that is increased menstrual blood loss, particularly due to the use of some copper device, that is an intrauterine copper device that can lead to menorrhagia, increased menstrual blood loss. In these cases we can use this. Recurrent epistaxis, high fever due to ocular trauma, bleeding peptic ulcer, in these cases we can use the tranexamic acid. Main side effects is the nausea and diarrhea. Thromboembolic events, disturbed color vision, allergic reaction can happen, or thrombophlebitis of the injected veins. Otherwise, these are the indications of the antifibrinolytic drug, most commonly used the tranexamic acid. Next, coming to the antiplatelet drugs. So already we have seen that platelet adherence and then platelet aggregation and binding of this platelet to the fibrin to the vascular endothelium ultimately leads to platelet plaque formation. So when we are using the antiplatelet drug, that ultimately inhibits this platelet adherence or platelet aggregation. So there are different materials that is either released from the platelet or released from the vascular endothelium that helps in this platelet adhesion and aggregation. For example, there is thrombin, there is ADP, there is fibrinogen. This ultimately binds with different receptors on the platelets and they helps in the platelet adhesion and aggregation. So if we are blocking these receptors or if we are blocking these materials, these materials that can causes platelet adhesion and aggregation, that can act as an antiplatelet drug. Okay. So plate disruption, when there is plate disruption, collagen and von Willebrand factor comes, they leads to platelet adhesion and aggregation, and ultimately from this thromboxane A2 and ADP is synthesized, and this thromboxane A2 is done by the cyclooxygenase, and cyclooxygenase inhibitor is the aspirin. Already in the NSAIDs class, non-steroidal anti-inflammatory drug, you have already read about the aspirin. Okay, so aspirin is an irreversible inhibitor of the cyclooxygenase. Apart from this, there is ADP. ADP can be blocked by means of this ticlopidine, clopidogrel, prasugrel, cangrelor, ticagrelor, etc. And after that, there will be platelet recruitment, and this platelet also attaches with the GP2B3A receptors, and there are some GP2B3A receptor inhibitor also, like abcipsimab, apitifibatide and tirofiban. That ultimately leads to platelet aggregation. So you can see Antiplatelet drugs may be some COX inhibitor like aspirin. Usually the low dose aspirin acts as an antiplatelet drug. Antiplatelet drug may be some purinergic receptor on which the ADP acts inhibitor. Like there may be ticlopidin, clopidogrel, prasugrel, cangrelor, ticagrelor. It may be some GP2B3A receptor antagonist like abciximab, epitifibetide, tirafiban. So in the nutshell, these are all the antiplatelet drugs and in different areas where the antiplatelet drug acts. So you can see this is the red string platelet. When the platelets are activated, there will be more platelet adhesion and aggregation. So you can see this is the platelet activation. So when there will be activated, the platelet receptors are upregulated. The fibrinogen comes, fibrinogen binds one platelet to another. So ultimately there will be platelet aggregation and platelet plaque formation. So aspirin, already we have read about the aspirin in the NSAID class. So aspirin basically an irreversible inhibitor of the cyclooxygenase. So when it inhibits the cyclooxygenase, there will be less synthesis of the thromboxane A2 as well as the less synthesis of the prostacyclin I2. But it has been seen that when we are using low dose of the aspirin, for example 75 to 150 milligram per day, it preferentially inhibits the thromboxane A2. This thromboxane A2 is a prothrombotic molecule. Prothrombotic means that ultimately leads to platelet adhesion and aggregation. So when we are using this low dose of the platelets, that blocks the thromboxane A2 synthesis, but that will not block the prostacyclin I2 synthesis. This prostacyclin I2 is synthesized from the vasculature and which is a vasodilatory material. That is, its action is just opposite of the prothrombotic. That is, it is a non-thrombotic material. But when we are using high doses of the aspirin, that dose that is required for the pain relief, that is basically mainly used as a non-steroidal anti-inflammatory drug. That is when aspirin is used in greater than 900 milligram per day dose, that blocks both the thromboxane A2 synthesis as well as the prostacyclin I2 synthesis. So ultimately that will not act as an antiplatelet drug. That's why the low dose platelet, low dose aspirin acts as an antiplatelet drug, but not the high dose platelet. So you can see aspirin induced prolongation of the bleeding time lasts for 5 to 7 days. Maximal inhibition of the platelet function occurs at the low dose, which is a 75 to 150 milligram per day. Inhibition of the cyclooxygenase 1 by aspirin in vessel wall also decreases the prostacyclin I2 synthesis. However, since intimal cells can synthesize fresh enzyme, activity returns rapidly, and in the low dose usually the blockade of the prostacyclin I2 synthesis will not happen. It is possible, already we have discussed, you can see this one, at low doses. What is the low dose? 75 to 150 milligram per day of the aspirin dose. Thromboxane A2 formation by the platelets is selectively suppressed. So thromboxane A2, which is a prothrombotic material, is selectively suppressed, but the prostacyclin I2 synthesis is not suppressed at all. Prostacyclin I2 is beneficial. This is a vasodilatory substance. It is not synthesis. But when it is used in a high dose aspirin is mainly used when we are using it as an anti-inflammatory agent greater than 900 milligram that can block both the thromboxane A2 as well as the prostacyclin I2. That's why it is not an antiplatelet drug. So you cannot say that aspirin is antiplatelet drug. You have to say that low dose aspirin is antiplatelet drug. Why low dose aspirin? It is clear. It also inhibits the release of the ADP from platelets and they are sticking to each other but has no effect on platelet survival time and their adhesion to the damaged vessel wall. Next is dipyridamole. Dipyridamole is basically another vasodilator which inhibits the phosphodiesterase enzyme also as well as the uptake of the adenosine, ultimately to increase the platelet CMP, which in turn potentiates the prostacyclin I2 and interferes with aggregation. So basically they blocks the phosphodiesterase and action of the prostacyclin I2 by a different mechanism, dipyridamole. So levels of the thromboxane I2 or prostacyclin are not altered, but platelet survival time is reduced by disease is normalized. So what happens? usually we have to use the combination of the aspirin plus dipyridamole, which decrease the incidence of the thromboembolism in patients with prosthetic heart valve when we are using this in combination with the aspirin or in combination with the warfarin. It also enhances the antiplatelet actions of the aspirin. So this combination may additionally lower the risk of stroke in patients with transient ischemic attack, but no additional benefits in prophylaxis of the myocardial infarction. So it has been seen, so if the patients, if there is more chances of the stroke, cerebral thromboembolism, we can use a combination of the aspirin plus dipyridamole. Ticlopidin is a newer one that alters the surface receptors on platelets, inhibits ADP as well as fibrinogen-induced platelet aggregation. So P2Y12, this is a receptor on which the ADP acts and ultimately platelet adhesion and aggregation happens. So basically they act with these purinergic receptors and blocks this. So there is no effect on platelet thromboxane A2, but bleeding time is prolonged and platelet survival is increased. It can again combined with aspirin, markedly lower incidence of the restenosis of the PCI, that is the coronary angioplasty, and stent thrombosis. But there are problems with the ticlopidin. There are some adverse effects. That is, there may be more chances of the bleeding and more chances of the neutropenia. So we have to monitor the WBC counts every week to see whether there is decrease of the RBC count or WBC count or not. That is the problem. There may be thrombocytopenia also, hemolysis and jaundice can also. So due to the presence of the adverse effects, most commonly neutropenia, thrombocytopenia, hemolysis, jaundice, etc., the use of the ticlopidin is less. Otherwise, we can use ticlopidin with aspirin, but the use is less. Now the newer ones like clopidogrel is very commonly used. You can see clopidogrel is a newer and more potent congener of the ticlopidin, has similar mechanism of action, that is, they act with the purinergic receptor P2Y12 receptors. That's why the ADP cannot act. They are blocking the ADP. ADP mainly helps in the platelet adhesion and aggregation. So this platelet adhesion and aggregation will be blocked. They irreversibly inhibits the platelet function and range of the therapeutic efficacy, but it is safer and better tolerated. Safer means there is lesser chances of the neutropenia, lesser chances of the thrombocytopenia, lesser chances of the bleeding when we are using the clopidogrel. We can use the combination of the aspirin and clopidogrel. The combination is synergistic that can prevent the ischemic episodes and utilized for checking the restenosis of the stented coronaries. So when the patient comes with myocardial infarction, we will do some stenting, that is coronary angioplasty. After that, we have to give some drugs so that there will not be again some thrombus formation and again there will be blockage. So usually for some first few years, first few months, we can use the dual antiplatelet therapy. What is the dual antiplatelet therapy? Dual action antiplatelet therapy, DAPT. We can use the combination of the low dose aspirin plus clopidogrel. Again, when a patient comes with myocardial infarction, immediately chest pain, ST segment elevated, already I have said that we have to give some loading doses of the drug orally. What are these loading doses? We can give the low dose aspirin, we can give this clopidogrel, and again we have to give the statins. Okay. So it is a slow acting drugs. Antiplatelet action takes about 4 hours to start and develops over days. It is slowly activated in the liver by the cytochrome 2C19. That's why clopidogrel also shows some genetic variability. That is, in some persons the clopidogrel will not act as it should act. The most important adverse effect is bleeding, but otherwise the chances of the bleeding is less in comparison to the previous ones. Prasugrel is the newest one. It is latest, most potent and faster acting P2Y12 purinergic receptor blocker, greater and more predictable inhibition of the ADP-induced platelet aggregation. Again, CYP2C19 is related, particularly suitable for use in ST segment elevated myocardial infarction. But again, there is problem of the life-threatening fatal and life-threatening bleeding. So because patients, if there is history of the prior stroke or transient ischemic attack, there are particularly high risks of the bleeding. It is contraindicated in those with a history of the cerebrovascular disease. So already we have seen there are different types of the purinergic receptor blockers. So you can see these are the purinergic receptor blockers. After aspirin, there may be some dipyridinol that basically acts somewhat in otherwise, that basically blocks the uptake of the adenosine. Apart from this, ticlopidin, clopidogrel and prasugrel. Of this, ticlopidin is lesser used nowadays because of its adverse effects like neutropenia, thrombocytopenia and hemolysis apart from bleeding. Prasugrel is the newest one, most potent one. It is very much beneficial in case of the myocardial infarction, but again there is more chances of the bleeding, life-threatening bleeding. That's why we have to keep a balance, and that's why we are using only the clopidogrel. Clopidogrel is basically in between this ticlopidin and prasugrel. There is less chances of the bleeding. They also, how the clopidogrel acts? Clopidogrel is a purinergic antagonist. They act with the purinergic receptor P2Y12 receptors. These receptors are present on the platelets, and on these platelets ADP acts. They are blocking this ADP, so platelet adhesion will not act. So in those patients, already there is more chances of the acute coronary syndrome, or if the patient have history of the ST segment elevated myocardial infarction, or if there is some history of the ischemic stroke, we can use the clopidogrel as a prophylactic therapy, as a therapeutic therapy in both of the cases. Next, coming to the silastazole. Silastazole is another oral antiplatelet agent that also has vasodilating activity, that basically blocks the phosphodiesterase type 3, which is an enzyme which prevents the degradation of the CAMP and increasing the level of the CAMP in platelets and vascular tissues. So ultimately that prevents the platelet aggregation, promotes vasodilatation of the blood vessels. They also favorably alter the lipid profile, cause a decrease in plasma triglyceride and increase in the HDL cholesterol. Mainly where this silastazole is used, silastazole is used when there is some blockade in the peripheral blood vessels, and that leads to intermittent claudication. That is, the patient will complain that after some times of the walking there is severe pain in the legs and the patient have to sit. This is known as the intermittent claudication that happens due to the blockade in the peripheral veins. So when there is intermittent claudication, we have to use the silastazole. Silastazole is another antiplatelet drug that is also a vasodilator that mainly acts on the phosphodiesterase type 3 and which mainly decreases the CAMP. It is extensively metabolized by the cytochrome enzymes. That's why dose modification may require when we are using some other drugs. Mainly it is eliminated through kidney. Headache, gastrointestinal side effects may happen. These have been shown to increase mortality in patients with advanced heart failure. As such, silastazole is contraindicated in patients with heart failure. If some patients are with heart failure, chronic heart failure, we should not use silastazole. It is mainly used. Remember, silastazole is indicated in intermittent claudication. Intermittent claudication happens due to the blockade in the peripheral veins. So you can see aspirin irreversibly inhibits the platelet cyclooxygenase. So from the membrane phospholipids in the NSAIDs chapter already we have seen, from the arachidonic acid metabolite, the prostacyclin I2 and the thromboxane are synthesized. The aspirin mainly blocks this cyclooxygenase 1. That's why thromboxane A2 synthesis is mainly blocked. And ticlopidin, clopidogrel, prasugrel, etc. mainly blocks here. That is from the damaged endothelial cells. They inhibit the ADP mediated platelet aggregation. Okay. So lastly, the glycoprotein GP2B3A receptor antagonists. There are three: abcipsimab, epitifibatide and tirofiban. Abcipsimab, epitifibatide and tirofiban, they are adenosine receptor or integrin on platelet surface for fibrinogen and von Willebrand factor, through which different agonists like collagen, thrombin, thromboxane A2, ADP, etc. acts and finally induce the platelet aggregation. So basically these are used parenterally. You can see this is the platelet phase. Already we have discussed about this. So these are the different platelets. These are the GP2B3A receptors where the different agonists can act and leads to platelet aggregation. And these are the ADP, these are the thrombin, von Willebrand factor, thromboxane A2. So this is the platelet phase, and all these antiplatelet drugs mainly acts in this platelet phase in one way or the another. So this is the active GP2B3A receptors. This is one platelet, this is another. So this abcipsimab, epitifibatide and tirofiban, they mainly blocks this GP2B3A receptor. So within these receptors, ultimately the different agonists come and leads to the platelet aggregation. So they are blocking this. Abciximab is the FAB fragment of a chimeric monoclonal antibody against GP2B3A protein. It also binds to vitronectin receptors on the platelet endothelial cells smooth blood vessels. Where it is used, mainly it is indicated with aspirin and heparin during the percutaneous coronary angioplasty. It has markedly reduced the incidence of the risk stenosis, subsequent myocardial infarction and death. So when we are doing the coronary angioplasty, we are giving the intravenous this GP2B3A receptor inhibitors like abciximab, epitifibatide or tirofiban, but these are the costly. This is non-antigenic, main risk is hemorrhage and thrombocytopenia. It should not be used second time since risks of the thrombocytopenia is there, constipation, ileus and arrhythmia can happen. So abciximab, so this is a monoclonal antibody, chimeric antibody. Epitifibatide is a synthetic peptide that selectively binds to platelet surface GP2B3A receptor and inhibits the platelet aggregation. In the similar way, its plasma T-half is longer, platelet inhibition reverses in a shorter time, bleeding and thrombocytopenia can happen. More or less the mechanism of action is similar. Tirofiban is another non-peptide but specific GP2B3A receptor antagonist. Plasma T-half is 2 hours, dissociates rapidly from the receptor. Again, it is used in acute coronary syndrome and angioplastic coronary intervention. So GP2B3A receptor inhibitors are mainly used during the percutaneous coronary intervention or coronary angioplasty to decrease the chances of the restenosis. Okay. So newer antiplatelet drugs like Cangrelor and Ticagrelor are there. Cangrelor and Ticagrelor also acts in the similar way like that of the Clopidogrel, that is they are purinergic receptor inhibitors. Usage is more or less similar, mainly used in the acute coronary syndromes. They are used compared, they can be used with aspirin, they can be used instead of the Clopidogrel, otherwise more or less similar. So uses of the antiplatelet drug, the aim of using antiplatelet drug is to prevent the intravascular thrombosis, that is within the vessels thrombosis. In most of the cases, if the patient have some ischemic heart disease, the acute coronary syndrome, if there is any history of the myocardial infarction, history of any blockade in different types of the vessels, we can use as a prophylaxis as well as the therapy these antiplatelet drugs like coronary artery disease, acute coronary syndrome or ACS, cerebrovascular disease, prosthetic heart valves and arteriovenous shunts, because if there is heart valve is changed, there is more chances of the embolism, more chances of the thrombosis, venous thromboembolism and peripheral vascular disease. So these are the usage of the antiplatelet drug. So you can see these are the different medications like aspirin, silastazole, clopidogrel, dipyridamole, prasugrel, ticlopidine, ticagrelor. These are the oral drugs, mainly these are used in oral drugs, and GP2B3A inhibitors like abciximab, epitifibatide and tirofiban, these are the injectable drugs. So in a nutshell, you can see this is the adverse effects. More or less we have seen drug interactions, there are some drug interactions and monitoring. Details is not required, but remember all the antiplatelet drugs, if they are combined with the anticoagulants, there are more chances of the bleeding. So you can see when they are combined with some anticoagulants, more chances of the bleeding. So antiplatelet drug like aspirin, remember the very important thing is low dose aspirin acts on antiplatelet drug, not the high dose aspirin. Why? It is clear. Low dose aspirin can be combined with some other antiplatelet drug, most commonly the clopidogrel. How the clopidogrel acts, it is clear. This aspirin, clopidogrel, apart from this, there are some other antiplatelet drugs. GP2B3A receptor antagonists, these are used injectively, mainly during the percutaneous coronary interventions to decrease the chances of the more thrombus formation. Apart from this, we have already discussed about the fibrinolytic drugs, mainly used as a life-saving drugs in case of the myocardial infarction. If the patient comes early within the 4.5 hours in case of the ischemic stroke and within the 4 to 6 hours in case of the myocardial infarction, and antifibrinolytic drugs, more commonly tranexamic acid, that is used if there is bleeding like from the tonsillectomy in case of the hemophilia, etc. etc.